A long time ago, in a uterus far, far away, there was a sexually undifferentiated embryo that could develop into either a male or a female, according to its sex chromosomes. During that time, most of its organs and systems took shape and started functioning. But one system, the reproductive system, developed and then waited for a trigger to kick into action. Even though we're born with differentiated male or female sex organs, it's not until puberty that they are fully mature, and that's when an individual becomes capable of reproduction. Sexual maturation is under the control of the hypothalamic pituitary gonadal axis. The hypothalamic pituitary gonadal axis is a system of hormone signaling between the hypothalamus, pituitary gland, and gonads, either the testes or ovaries, to control sexual development and reproduction. Gonadotropin-releasing hormone, or GnRH, is released into the hypophyseal portal system, which is a network of capillaries connecting the hypothalamus to the hypophysis, or pituitary. When gonadotropin-releasing hormone reaches the anterior lobe of the pituitary gland, it stimulates cells called gonadotrophs to release gonadotropin hormones, luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH, into the blood. These gonadotropin hormones then stimulate the gonads to produce sex-specific hormones, which are estrogen and progesterone in females, and testosterone in males. Now, the amount of hormone that gets produced by this axis varies over a person's lifetime, and that affects the development of the sex organs, as well as the appearance of secondary sexual characteristics. GnRH secretion begins during week 4 of intrauterine life, and the pituitary starts secreting FSH and LH between weeks 10 and 12. But after a mid-pregnancy peak, levels of these hormones drop. Once the baby is born, secretion of GnRH, FSH, and LH continues, but the levels remain low throughout childhood, with the FSH level being higher than the LH level. Puberty begins when a part of the hypothalamus called the pulse generator, or the tonic center, begins secreting GnRH in, pulses. Sometimes secreting a little bit more GnRH and sometimes a bit less. The pulse generator starts doing this between age 10 to 14 in females and age 12 to 16 in males. Pulses of GnRH lead to pulsatile secretion of LH and FSH. At first, large LH pulses occur at night, during the REM phase of sleep. As puberty advances, both LH and FSH pulses start happening during the day. Over time, they become more frequent. Also, in puberty, the GnRH receptors in the anterior pituitary become more sensitive to GnRH stimulation. So a small increase in GnRH leads to a large increase in FSH and LH levels. In some, these changes lead to a change in the FSH to LH ratio, with LH levels becoming higher than FSH. The pulsatile secretion of FSH and LH causes the gonads to produce sex hormones and gametes, sperm in males and oocytes in females. In males, the pulses of FSH and LH act on the Leydig and Sertoli cells in the testes. Leydig cells respond to LH by producing testosterone, while Sertoli cells respond to FSH by kickstarting the production of sperm. In females, FSH and LH act on the ovarian follicles, which are scattered inside the ovaries. Each ovarian follicle is made up of a ring of granulosa and theca cells surrounding a primary oocyte at its core. Theca cells respond to LH by producing androstenedione, an androgen. Then the granulosa cells respond to FSH by converting the androstenedione into estrogen and progesterone. However, in the female hypothalamus, there's also a region called the surge, or cyclic center, which makes FSH and LH levels vary over the menstrual cycle. The menstrual cycle lasts 28 days on average, and is centered around a surge of FSH and LH happening on day 14, which makes ovulation possible. At ovulation, the primary oocyte develops into a secondary oocyte, the female gamete, which is released from the ovarian follicle into the fallopian tube, where it can be fertilized by a sperm. These variations in FSH and LH levels result in fluctuating levels of estrogen and progesterone that vary according to the phases of the menstrual cycle. 2 weeks before ovulation are called the follicular phase. during which the granulosa cells produce mostly estrogen. The 2 weeks following ovulation are called the luteal phase, during which the granulosa cells produce more progesterone instead. The increased production of sex hormones drives the development of primary and secondary sex characteristics in both sexes. Primary sex characteristics refers to the genitals, which are the organs directly involved in sexual reproduction. Secondary sex characteristics refers to any sex-specific physical characteristic that's not directly involved or necessary in sexual reproduction, like the growth of pubic hair in both sexes, the deepening of the voice in males, and the development of breasts in females. These characteristics can be evaluated with the Tanner scale, which represents a predictable set of steps that males and females go through at puberty as they develop primary and secondary sex characteristics and become more sexually mature. The Tanner scale centers on 2 independent criteria: the appearance of pubic hair in both sexes, the increase in testicular volume and penile size and length in males, and breast development in females. There are 5 stages. In stage 1, the prepubertal stage, no pubic hair is present in either sex. Males have a small penis and testes, and females have a flat chest. In stage 2, soft pubic hair appears. There is a measurable enlargement of the testes, and breast buds appear. In stage 3, pubic hair becomes coarser, the penis begins to enlarge in both size and length, and breast mounds form. In stage 4, pubic hair begins to cover the pubic area, and penis begins to widen, and breast enlargement continues to form a mound-on-mound contour of the breast. In stage 5, pubic hair extends to the inner thigh, the penis and testes have enlarged to adult size, and the breast takes on an adult contour. Alright, as a quick recap. During puberty, the sex organs mature functionally and begin producing sex hormones and gametes. Puberty begins when the hypothalamus and the pituitary switch from a linear pattern of GnRH, FSH, and LH secretion to a pulsatile pattern. In addition, in females, there's also a 28-day cycle of gonadotropin secretion called the menstrual cycle. The increased production of sex hormones determines the development of primary and secondary sex characteristics in both sexes, and these characteristics can be evaluated with the Tanner scale. Breast milk is pretty amazing. It has all of the nutrients that a baby needs in the first 6 months of life. The benefits for the baby are impressive. They include lower rates of allergies, ear and lung infections, obesity, and sudden infant death, as well as healthier weight gain and other long-term outcomes. That's compared to infants given cow milk formula. Moms can benefit from breastfeeding too. It reduces uterine bleeding, burns calories, and decreases the risk of breast, ovarian, and uterine cancer, as well as osteoporosis, arthritis, type 2 diabetes, and heart disease. Finally, breastfeeding is free and offers mothers and babies a valuable opportunity to bond from the very first skin-to-skin contact, which should start minutes after birth. To understand breastfeeding, let's start with the breasts themselves. Breast tissue develops during puberty and is made up of adipose or fat tissue, as well as glandular tissue that makes the milk, and lactiferous ducts, which serve as passageways which guide the milk to the nipple. Zooming in on the glandular tissue, there's the alveolus, which is a modified sweat gland made up of alveolar cells which actually make the breast milk. Wrapping around the alveolus are special myoepithelial cells that squeeze down and push the milk out of the alveolus, down the lactiferous ducts, and out of one of the pores on the nipple, at which point it enters the baby's mouth. When the breasts are full of milk, they can get heavy, and there are suspensory ligaments called Cooper's ligaments, which help hold them up against the chest wall. During pregnancy, the placenta releases human placental lactogen and progesterone, and the anterior pituitary gland releases prolactin, and all 3 of these hormones stimulate the growth of more glandular tissue and prepare the alveolar cells to produce milk. However, even though the breasts are capable of making milk by mid-pregnancy, the high levels of progesterone associated with pregnancy prevent milk letdown. So, during pregnancy, the breasts usually don't release milk, except from occasional leakages from the nipple. Overall, the breasts enlarge, the area around the nipple, called the areola, begins to darken, and the areolar glands, also called Montgomery glands, which look like bumps on the areola, start to produce lipoid fluid, which moisturizes the nipple. Once the baby's delivered, though, the placenta, or afterbirth, is also delivered. So placental progesterone disappears, and milk begins to flow. Initially, though, the breasts don't actually make milk, they make colostrum, which is a yellowish fluid that's rich in immune cells and antibodies, but low in fat. Colostrum coats the baby's gastrointestinal tract, and has a laxative effect, which helps the baby pass the first stool, which is called meconium. Within a few days after delivery, the breasts start producing milk, which, relative to colostrum, has a much higher fat content. In fact, the amount of fat in milk also varies during a feeding session. When milk is sitting in the breast, fat globules stick to the alveolar walls, rather than moving into the lactiferous ducts. So when a baby begins feeding and drinks the milk that was in the lactiferous ducts first, that milk has a relatively low fat content. The process of feeding, though, increases the milk flow, and those fat globules get swept into the lactiferous ducts, causing the fat content of the milk to steadily increase as the feeding session continues. Breast milk also contains lactose, vitamins, micronutrients, and various proteins like casein and maternal antibodies. Most importantly, secretory IgA, which supplements the baby's gastrointestinal immune system. The amount of vitamin D in the breast milk is typically insufficient for bone health, and this is because of the modern, mostly indoor life of newborns, so often supplemental vitamin D is needed. Now, milk letdown is a conditioned reflex, and it usually starts with the baby latching and sucking on the breast. A good latch is one in which the baby's mouth is wide open, covering the areola with the lips flanged out, the nipple up against the roof of the mouth, and the baby's tongue up against the bottom of the areola. Mechanoreceptors in the nipple sense this stimulation and send a signal via intercostal nerves to the dorsal root ganglion, then via the spinal cord to the hypothalamus. When the hypothalamus gets that signal, two things happen. First, the hypothalamus blocks prolactin-inhibiting neurons from releasing dopamine, which allows lactotrophic cells in the anterior pituitary to make prolactin. Second, the hypothalamus stimulates a group of hypothalamic paraventricular cells to produce oxytocin, which is then sent down the pituitary stalk to the posterior pituitary, where it's secreted. Now, prolactin stimulates alveolar cell milk production, and oxytocin stimulates the myoepithelial cells to contract, which pushes that milk into the ducts, a process called milk letdown. Interestingly, sometimes when a baby cries, the sound triggers a signal in mom's brain and is sent to the hypothalamus to initiate the letdown reflex as well. After delivery, mothers are able to produce more and more milk, and in the first week, the baby's stomach starts to stretch out and goes from the size of a blueberry to the size of a walnut. While the baby's stomach is small and the mother is making colostrum, it's normal to see a dip in the baby's weight, but typically no more than 7% of the birth weight. But by the second week of life, that weight's usually completely regained. These early weeks are critical to both mother and the baby. During the first few weeks, newborns feed about every 1 to 2 hours, and at maximum every 3 hours, for a total of 8 to 12 feeds a day. The first few months of breastfeeding after delivery are largely driven by prolactin. After those first few months, it becomes more mechanically based, where mom's body produces the amount it needs to replace what was taken by the infant, meaning that it's more supply and demand. The most critical thing to establishing a stable, long-term supply of breast milk is allowing the baby to frequently empty the breasts, because that stimulates the glandular tissue to make even more milk. After a good feeding, the breast typically feels soft and empty, and the baby looks calm and relaxed. The reverse of this is also true. As an infant grows older and stops breastfeeding, the glandular structures involute or shrivel, and the breasts stop producing milk. For producing milk, A healthy, balanced diet is all that is needed to make high-quality breast milk. And although food can flavor milk, there are no particular foods that should be avoided while breastfeeding. A top concern for most mothers is being able to produce enough milk for a baby. And stress, some medications like decongestants, and dehydration can all affect milk supply. In general, the biggest impediment to establishing a good milk supply is the introduction of formula and not being able to regularly breastfeed, two issues that go hand in hand. Fortunately, societal pressures are growing to make breastfeeding in public spaces more acceptable, and manual or mechanical breast pumps make it easy to express milk and store it for later. A breast pump can also help a mother increase her milk supply by helping to fully empty her breasts if there is some extra milk. In the early weeks, it's normal for first-time moms to have some nipple sensitivity and discomfort, though it should not usually be severe and typically diminishes after the first few days. Occasionally, there can be nipple cracking, which is treated with topical creams or ointments. Also, moms might experience breast tenderness from a blocked milk duct, which typically improves with warmth and continued breastfeeding to keep milk flowing steadily. A shallow latch can also cause nipple soreness, cracking, and bleeding. This is because a shallow latch allows the sensitive nipple skin to press against the hard roof of the baby's mouth. A good latch places the nipple further back inside the baby's mouth, where it's soft and flexible. This is achieved by making sure the bottom of the areola is inside the baby's mouth. Since a good latch can make a huge difference when it comes to breastfeeding success, it's important to try out different positions for both mom and baby to find one that helps the baby latch on well. For contraindications to breastfeeding, maternal use of certain medications and illicit drugs like cocaine, heroin, and cannabis preclude breastfeeding altogether because they can harm a developing baby. Alcohol is also thought to blunt the letdown reflex and affect the baby's development because it gets into the breast milk, so alcohol should be minimized while breastfeeding. Breastfeeding should take place at least 2 hours after an alcoholic drink. Maternal smoking increases the risk of sudden infant death syndrome and infant respiratory allergy. And even high doses of caffeine can get into the breast milk and alter the baby's physiology. In addition, maternal infections like HIV are also a contraindication to breastfeeding in high-income settings, but it might be appropriate in low-income settings where other factors such as the cost of formula and access to clean waters are a serious challenge. Remember, breastfeeding isn't always easy. It can be exhausting, frustrating, and can be both emotionally difficult and physically uncomfortable. And not every mother will choose to breastfeed for a variety of reasons. Ultimately, the most important thing for a baby is to bond with a happy, healthy mom. So if breastfeeding is causing undue stress and anxiety, supplementing with a balanced formula can be a healthy alternative. Alright, as a quick recap, breast milk is perfectly designed food for infants, and breastfeeding has benefits for both baby and mom. During pregnancy, human placental lactogen, progesterone, and prolactin gets the breast ready for milk production. And after birth, when progesterone goes away, prolactin and oxytocin, combined with the sucking reflex, establish and continue the production of milk.